Yeah, looks good. Good.
Okay, all right. So thank you everyone for joining us. It's a very wet and cold midday. We were actually gathered here to sort of discuss something about reflective practice, and it's one of the programs that we have actually sort of initially embarked as a educational problem research, and through Dr. Farida's effort, we have actually sort of used the information we gathered from research and implement it into a program that has been running for about 2 or 3 years now. So we thought that it's actually a very good so-called sharing. Especially if you identify the same educational problems in your program or your department, you can actually consider getting some materials from us and try on your department and your learners. Okay, so let me introduce Farida as well. Farida is actually a senior consultant in women's anesthesia and in KK Hospital, and Farida is our long time supervisor of training. Even before residency, she was a supervisor of training for 15 years, Farida.
Yeah, better don't say so much about the years.
Yeah.
Discover my age.
Yes. So just now we were chatting, and Farida and myself were reflecting that we have actually known each other for about 25 years, working together, right? And
taking the exam together, yes.
Yes, that's right. And also would like to introduce Dr. Jacqueline Yet. Dr. Yet is actually our chief resident in our SingHealth Anesthesia residency program. And Jacqueline will actually be sharing with us some of her learning experiences in using the reflective portfolio that we've actually planned for our learners. Okay, all right. So let me just advance the slides. Yeah. So a short summary of what we want to talk about today. All right. Some critical analysis of some of the educational challenges that we observe in our anesthesia program, and how we actually would want to use evidence-based refractive practice and theories in crafting a refractive program and portfolio in our experience. Okay, and also really sharing what really needs to be done to make this program sustainable, and some of the ongoing challenges that we have, so that if you're thinking of actually instituting the similar programs, some of the things that you should be looking out for. So for anesthesia training, right, I think similar to quite a lot of the other specialties, we are a mix between theoretical training as well as clinical training. And we do focus quite a lot on stuff like deliberate practice, whereby ACGMEI actually mandates that our residents need to do X numbers of procedures, like 40 spinal, 40 epidurals, right? I think progressively for undergrad education as well, we do specify the number of cases that medical students will need to do in order to sort of gain procedural competency, right? And a lot of times we also focus on situated learning. We tell our learners that it's not just the numbers, but it's actually the overall learning experience and being able to work in a system of other stakeholders, as well as mentorship. Okay? So these are our ideals. And but what we sort of would like to sort of discuss is that progressively we are defining competence or clinical competence not just by knowledge or technical skills, but by things like clinical reflection, reasoning, right? And we do value the importance of communicating with our patients and their family members as well, right? At the same time, showing resilience, empathy, and abiding by values of our educational system. So it's a realization that clinical training is actually not just simply imparting knowledge of technical skills, or which actually a lot of our assessment systems are based on, but the higher order values that actually we want to impart to our learners. Okay, and something that we have to be conscious about is that learners do choose what they want to learn, and they will learn better if they sort of realize that something is important to them or something that's useful to them, right? So if you tell them that this question is coming out for your final year exams, I'm sure they'll learn, right? They will learn, they'll ask questions about that. But but we do appreciate that they actually have a limited capacity, all right, in terms of working memory. But especially for clinical learners, I think beyond medical knowledge, situated learning is actually very important, right? Why do we arrange for medical students and postgrad learners into labor ward, OT, general ward, emergency departments? Is that we hope that they actually would learn from the clinical environment, right? But how much they actually take away from learning in these environments are actually very much governed by their emotional and motivation factors, and how welcoming they are to expose themselves to the other stakeholders for learning. Okay, so when we actually look at the so-called key elements in our clinical training, right? I will say that in our anesthesia training, we focus very much on knowledge transfer and problem solving, but we are actually not focusing a lot on teaching, assessing, and evaluating critical thinking. So hence, one of the reasons why we actually would want to instill reflective practice and introduce a portfolio is actually an overall goal of actually in improving critical reasoning and thinking training in our program. Okay, so why is it important? Because I think with it's actually important for situational awareness in the sense that as a learner go through our training program, right, we hope that by being able to acquire information and process information and building a mental model, they will have this situational awareness whereby as a specialist doctor, they will actually learn to use this situational awareness to predict problems. Okay, so now what are some of the weaknesses that we sort of identify in our system, especially in a procedural training program like anesthesia, right? So I think number one is that a learner doesn't exist in isolation in the classroom. So they do need to learn how to manage the demands of working in a very stressful environment like the operating theater or emergency department, right? And besides the curriculum and the learning objectives, we actually they will also need to sort of learn how to manage patient and stakeholder expectations, which actually has been increasing, right? Especially during the pandemic. The other thing that we actually realize is that while the Miller's pyramid actually stacked very nicely into knows, shows, and does, right? A lot of our trainees, they sometimes can do things without knowing or do not know the theoretical basis or the scientific basis or the reasons why we do things. So it's like imitation, okay, of what the specialist does in the clinical area, right? So for those of you who's actually familiar with complex learning, this is actually one of the models of complex learning, whereby the model actually says that with deliberate practice, right, the learner is actually supposed to gain experience from the previous, learn from the previous, so that he learns how to deal with the next patient better. All right. So this is actually so-called constructivism in ideals in training. But we find that in absence of reflective practice, this constructivism actually do not stack very well. And we'll explain to you some of our observations. Okay. So I think one of the biggest impediment we actually found, and this was actually found from one of our study, is that feedback is actually not being offered very timely and appropriately. Sometimes when we actually do try to give feedback to our residents, they perceive feedback as a negative feedback rather than a positive feedback. And I think at the same time, the residents are actually quite fearful of asking for feedback for fear of being judged by the faculty. All right. One thing that was actually quite striking that we actually found was that the residents they actually do not reflect from positive learning. They only reflect when a negative feedback has been given or so-called scolding given by a faculty, which is actually not very healthy, right? And it sort of made us a bit worried because with poor feedback or not in time feedback, their morale actually can be affected. And this statement from a resident actually sort of affected us quite a lot. I'm sure myself and Farida, we are actually quite affected by this in the sense that it affects the way that you teach people in the future, right? So which means that if we actually want to teach a generation of reflective physicians, we actually have to have a sort of a defibrillation and restart the system, to make sure that we start right from square one again. Okay, all right. And some input from the faculty, when you try to give feedback, the residents look at you as though they have done something wrong or stuff like that. Okay, all right. And articulation is another problem that we see. All right. A lot of times the residents are very reluctant to ask questions. Okay, for the fear of being judged. Perhaps our residency system is actually too competitive. They are actually fearful of appearing inadequate if they were to ask questions. So they will actually rather box up their questions in them. And in that case, they actually will not be able to get any feedback to actually start the reflective cycle. Okay, yeah. So I'll go on to this. Yeah. So when we actually sort of look at the program and try to craft the program, we were thinking that it has to be evidence-based, and we actually base the program on reflection theories, of which there are actually many reflection theories out there that you can actually choose to use. There are also many reflective cycles or models or framework that you can actually use as well. Okay, but we choose something called the ALEC model. Okay, let me show you. Which is a 5-step circle. We choose this because it's simple. The words are so-called easy to understand. And we communicated this cycle to our residents and faculty, right? There are some cycles out there that are fairly complicated, more than 5 steps. In fact, I think some are 8 steps. So in choosing a framework, what we advise you to do is actually to choose a very simple step that people can remember. So now when we actually talk about the ALEC model, everybody sort of kind of know what we're actually talking about. And how we like about this model is a single word, action, looking back, awareness, creation, trial. So it's quite easy, even for myself and Farida to sort of remember these keywords. Okay. Right? So with this, we actually started a reflection portfolio. So now I'll actually, perhaps Farida, before we describe the portfolio, shall we ask the audience whether do they observe or face similar educational problems in their situation? Anyone would like to share?
Okay, I will share.
Hi, Lily.
Yeah, hi. I just want to say that reflection requires either superficial or deep thinking. So not everyone is comfortable in doing deep and deeper thinking. That is why sometimes unpleasant experiences are very hard to speak up for learners, and many wish to be forgotten because it is very uncomfortable to talk about it. So the article that we shared is really talk about reflection, and there is a structure, negative, positive feedback, and what you have shared just now. So what I'm trying to get is like all those blind spots. I call this blind spots for learners. Maybe cannot see because they didn't want to reflect or not comfortable reflect things so much. So it stops there, you see. And how do we actually unopen this, draw them out to talk about it? To me, it's a very challenging as an educator. Just my thoughts. Yeah, I do not know what the rest think.
Thank you, Liming. I think you're quite right because the ability to reflect, right, meaningfully could be a inherent personality trait that each of us would have difference in quality. And later Farida can actually share that her encounters with our residents, right? Some people are natural reflectors. Some people just simply struggle to reflect. And it's actually very interesting in the way that they craft a response in the portfolio. All right. So maybe Farida, we can actually discuss that after your sharing, right? Yeah. Any other inputs from the audience? Anyone?
Yeah.
Nigel, what do you think?
Hi, Raymond. Yeah, so just also wanted to share that, like Damien, we have struggles with learners providing different depths of reflection. And very often, sometimes the depth of reflection is superficial only in the sense of them reflecting on what they learned, but very often they are very reluctant to go into how they felt. I was stressed during the simulation. I was upset that I didn't get the diagnosis, that sort of thing. So it sometimes needs a bit more prompting. I think perhaps our Asian culture also doesn't maybe give us the language to describe our emotions or the freedom to describe our emotions.
Thank you very much. Actually, the points you raise about learners' experience in reflection, whether or not if you would want someone to reflect and without training, does it actually make a difference? And even with training, would you expect different successes in reflective practice? All right. So these are all very good points that I think Farida will be touching on. Farida, would you want to carry on?
Okay, can you see my slides?
Yes, full screen. Yeah.
Yeah. How
Great.
about now? Is it full screen?
Yep.
Yes. Okay. All right. So I'll go on and describe a little bit more and share our experience with the reflective learning. So I'll start off with what is reflection actually? Reflection is the mental process of trying to structure or rather restructure or reframing and experience a problem or existing knowledge or insights for the purpose of learning. Then we call it a reflective learning and or improve a practice, which is then a reflective practice. So this reflection can actually take place after an action. So we call that a reflection on action or during the action itself, which is a reflection in action. Okay. All right, next slide. Okay. So feedback, as Raymond said earlier on, right, also has an important role in enhancing reflection. Okay, so reflection only occurs when specific feedback is provided or like a prompt, and learners who reflect on their performance are more likely to make full use of this feedback. Okay, so in our previous study looking into the barriers in anesthesia training, we found that daily performance at work for feedback to the resident was rather poor. A resident stated here that he or she tend to reflect less unless something such as a mistake or poor outcome has occurred. And then they will reflect on it and how it can be done differently in the future. A faculty also shared that even when they asked them, the resident, to reflect on a patient's management, they look as though something that is not normal. Okay, the response is, am I supposed to, or is there something wrong with what I did, right? Importantly, the residents' good performance were not being recognized then, and their misconception were not corrected. So this omission of feedback and reflective practice could result in a potential patient complication and even undesirable outcome. Okay, several barriers has been identified, okay, which were multifactorial in nature and consistent with other international studies. The common barriers could be due to either clinical pressures and uncertainties in gauging procedural experience. So in terms of clinical pressures, it could be due to high clinical load in running a busy or a high turnover list where they need to get cases going. Hence, there is no time to think or even discuss on the learning points. So patient factors in our setting where patient is most of the time awake under regional anesthesia, and this could increase stress and anxiety for the whole team who's managing, and hence not much space or opportunities to provide feedback. Residents might have to do multiple tasking, and this could lead to distractions as well. And that might be concerns with incurring clinical risk, and therefore a lower threshold for faculty in allowing residents to perform a procedure. disagreements within anesthesia team or with the surgeon, okay, may create tension atmosphere and not conducive for learning. Okay, so in terms of uncertainties in engaging procedure experience, this could be due to poor communication between the training sites or short training rotations, like 2-3 months or some even 1 month, right? Lack in monitoring tools and assignment of to different faculty, right? So there's no continuation. There could be lack of a safe climate to speak up due to multiple reasons, such as feeling vulnerable in revealing deficiencies, concern with their training and career progression. And it could be the collective outlook of the Asian culture, just reluctant to do so, right? Strong hierarchical system and concern with a high stakes outcome. There could also be a lack of learning climate for feedback, okay, contributed by the presence of high expectation and narrow margin of errors in anesthesia, okay, and association with medical errors and blame culture, time pressures, delayed and low quality feedback, okay, possibly due to lack of faculty and resident training as well. And lastly, reflective learning and practice are not used actively as a learning tool. And one of the key identified barriers was the lack of stimulus or reflective learning and practice. Okay, so reflective learning and practice can actually result in a transfer from superficial to deep learning, as shared by Limin just now, right? New experiences alone do not necessarily lead to learning. So a stimulus is necessary to trigger interest and curiosity. Therefore, reflection must be deliberate in order to achieve a deeper learning and understanding. Okay, so what are superficial versus deep learning? What does it mean, okay, and how to differentiate them? So basically, superficial reflection is considered to occur when there is only description of the event, but deeper reflections include stepping back from the event and actions with evidence of challenge and possibly change to existing belief and perspective. Surface learning approach, which also means cognitively passive learning behaviors, such as, for example, I came to work, I reviewed the procedure list, I checked the indication and contraindications, and I performed the procedure like my senior, okay? Whereas in a deep learning approach, where there's cognitively active learning behaviors, you will be thinking as I came to work with some questions from my previous day's experience, I reviewed the procedure list and analyzed the priorities and resources, okay? And then we'll be thinking how to perform the procedure better next time. So there are different levels of reflection, and this hierarchical model is based on the concept of depth of reflection. So for diffuse reporting, it's describing the event with poor description, or is just repeating the details of the event without offering any interpretation. For objective reporting, as describing of the event with recognizing that something is important, but not really explaining why. Okay, for emotional exploration, describing the event, recognizing how it affects one's feelings, attitudes, beliefs, and values. There's also questioning what has been learned and comparing it to the previous experience. This involves judgment as well, as in what went well, what less well, or and why. Okay, for committed reflection, there is experiencing an event which has changed or confirmed how one experienced the events. Okay, and they may wish to change how to respond to a similar event in future, and some presentation of evidence to back up this should be provided. And this deeper level of learning is equivalent to when transformative learning actually takes place. So what are the enablers for reflection? Okay, there was some evidence of an improved quality of reflection as learners strive for some control in their own learning. So a greater effort at reflection is associated with positive learning experience, and there was a strong correlation between reflection and both conceptualization and positive learning experience, and that learners who seek understanding of what they learn derive a more satisfying and meaningful experience. Okay, this reflective practice is likely to be expected when facing a complex or unusual cases. Portfolio were advocated as an instrument for stimulating reflection. Okay, and a trained supervisor or mentor can be invaluable to provide learners with effective feedback and thus promote reflection. Okay, some suggested uses of reflection according to the literatures and can be useful for formative and summative purpose. So in our experience, it has been used in formative and remediation process. Okay. An argument against combining reflection and assessment is that this assessment can actually jeopardize the quality of reflection. Okay, reflection can be hampered because students may be reluctant to show their less successful efforts at specific tasks and reflect on what they can do to improve. If they run the risk that showing the less successful effort will turn against them in an assessment situation. But as a counter argument is that assessment directs the learning of the students, implying that when portfolio is not being assessed, students are less likely to invest time in compiling or completing one. Okay, hence there's always a balance, trying to strike a balance between assessment for support and assessment for high-stake decision making. Okay, so for remediation purpose, we have a few cases from our experience. It was useful as guided reflection and feedback. Okay, and these are done by the mentor during the remediation period. Okay, so this is the obstetric anesthesia reflective learning diary that we have created. So it is to create the stimulus for reflective learning. We introduced this reflective practice curriculum using the obstetric anesthesia reflective learning diary. And this is to stimulate kind of a reflection on action. Okay? So as mentioned by Raymond earlier, this is based on the ALEC model. So we adopt it to describe the spiral process, okay, in which our residents should effectively learn when faced with a situation for which there is no routine plan available. So this diary is created and applied appropriately to different levels of residency training. So we have R2, R3, and also SR. And this is to facilitate structured reflections as residents' own time. So to complete the experiential learning cycle, they will discuss their reflections with their mentor, okay, who will initiate a reflective feedback, which will also act as a stimuli for creating alternative methods and trial in the spiral of learning. So residents were reassured that their reflection would not be counted towards their evaluation. So the residents are asked to complete the reflective diary after a specific learning or work experience, which could cover all aspects of knowledge, skill, and attitude appropriate to their training level. So this example in R2, where they will reflect their self-learning abilities in the knowledge aspect, their first epidural insertion experience, or skill and co-managing a complication or unfavorable outcome. And same goes for the R3 residents, where they have the opportunities to reflect their stresses at work in training, managing a challenging or complex case, and they can reflect on the end of posting evaluation and feedback. And this is for SR, where they reflect their role as an educator and their first solo registrar call, okay? And later we will share, one of our SR will share the reflection in this, as well as how sharing working as part of an interprofessional team and in managing or co-managing a critical case or crisis. So this example of a reflection, these are the questions. So under each section of the knowledge, skill, and attitude, we have we have developed open-ended questions, include that hopefully will stimulate some written reflection of 200 to 500 words. For example, these are the guiding questions for the R2, okay, year 2 resident in their skill to describe their first OB epidural insertion. So when they encounter with a patient, describe how they feel, and they are advised to grade their success of the attempt and in what areas they did well. So they are asked to describe how would they do differently, okay, during the next encounter, and what were the and if they were the patient, how would they feel about the encounter? Okay. So this is an example of the R2 who had reflected in the skill of when they come to learn with us. So first of all, I did not revise important topics in obstetrics, except those covered briefly in Oxford Handbook, such as stages of labor, which is very important because we won't be posted to labor ward. Secondly, I had difficulty with successfully performing spinal in obese patient and epidural at the beginning. I was grateful that in anesthesia, there was direct supervision during procedure, and I was given immediate feedback and advice for troubleshooting. Okay, it was practical knowledge that cannot be obtained from textbook. Thirdly, I realized I was not very sure when it details of management, for example, how much oxytocin to give after the baby is delivered. I asked different faculty the reason behind their practice. Something else that I have done is to look up on the literature, on the studies performed, and get the latest evidence. So these are really true reflection by our year 2 residents. Okay. So I like to, at this stage, I would like to invite Jacqueline, who is our chief resident, to share some of her reflection. Okay, during her training with us. Jacqueline,
Okay,
you want to unmute? Yeah.
Good afternoon, everyone. So yeah, I'm Jacqueline, one of the SR1. So I would like to reflect on, share my reflections on my first on-call. We're going to do the on-call one first, right, Dr. Farida? I think
Yes.
it clicked
Hang
on.
on.
Okay.
I clicked that. Oops, sorry.
Okay, so I guess I'll just begin. So prior to starting
you
my
can.
first registrar call, I was quite apprehensive because I had some fair warning from my colleagues who said that women anesthesia had one of the worst registrar calls in terms of dealing with people and the tasks that all had to be attended to stat. So the tech calls were very useful for me as I got various advice from different consultants on how they would manage the team, the workload, and the people there. And I chose what was suitable for myself. When I experienced my first own registrar call, indeed the phone didn't stop ringing and every patient had to be dealt with almost immediately. But this allowed time to pass quickly and I felt quite relieved that the call had ended after. So calls in women's anesthesia requires a lot of manpower management, resource allocation, and communication with the team, especially during crisis, and also a lot of management of the patients as well and their expectations. In addition to that, being the only, as I can so-called say, like medically trained specialist in a whole hospital, I made the effort to always revise like emergencies in my head, especially my ACLS and BCLS protocols just before the call so that I can be more prepared if I were to deal with such a crisis. So some strategies that I picked up to manage my team and resources was to understand the capabilities of my team members before the call and know that whatever roles they've been assigned to are fluid, such that if the situation requires, I can move the manpower to appropriate locations. So this means like sometimes I have a labor ward MO who is quite senior. I can actually move the MO to the OT or vice versa if I require the appropriate manpower and capabilities. So other reflecting back, some gaps that I identified would be, now that turning SR, I probably have to step out of my role as an MO and become a leader instead. So as MO, I always happen to be at the patient's head, managing the airway, but now as a team leader, I feel that it's more important to take a holistic view of the patient and instead instruct the team. So while I haven't had much bad call luck so far, codes have been not very frequent for myself. I always take the opportunity to watch other people conduct codes and simulations and always learn from different ways on how to improve my non-technical skills. Yeah, so that's my reflection about on calls.
Okay, I'll let you continue with sharing your reflection for the next case that you manage when you're on call.
Okay, so I was going to reflect on one of the challenging cases I had. So this was in Changi. It was a very busy night, and at 6 a.m. I was called to attend to an airway code in the A&E for an intoxicated patient who had multiple slash wounds across his neck, his forearms, and his feet. So after the CT scans were done, the surgical team assessed that the patient was hemodynamically stable. None of the major arterial vasculatures had been compromised, but would require emergent surgery to explore the wounds and repair any cut structures. So prior to surgery, he had lost an unquantifiable amount of blood, but was hemodynamically stable. After fluid resuscitation, he had 2 peripheral IV plugs. So I proceeded with a general anesthesia, rapid sequence induction with an intra-arterial line after induction. So 10 minutes into surgery, when the GS team was at the neck and the orthopedics team was at the lower limb and the patient was fully draped, I noted that there was a sudden drop in his blood pressure, and despite giving all 10 mils of my phenylephrine, the blood pressure still remained at 40/30. So I immediately voiced my concerns to both teams and asked them if there was any bleeding at any of the sites that they were operating on, and both denied. So immediately I went on to look under the drapes and saw that there was a pool of blood underneath the antecubital fossa, and I voiced that concern out that there is some bleeding over here, and immediately the surgical registrar turned over to inspect and noted a spurting vessel. So we applied a tourniquet and proceeded with the repair of the cut structures. So on hindsight, what I learned was that probably he had a lot of blood loss, he was vasoconstricted, and the after effects of fluid resuscitation and GA with the vasodilatation or a possible dislodgement of a hemostatic plug may have resulted in the bleeding being found much later. And one of the aggravating factors of this situation was, although the patient had 2 IV plugs, one was actually bumped, and the only one that I had was on the same arm of the bleeding side. So that was quite unexpected for myself. And in addition, this was like a fully draped patient, so all the bleeding was masked under the drapes. The patient was also intoxicated, so that prevented me from taking a proper history. I wasn't sure if there was any confounding factors of drug usage that might have resulted as well. And also with the surgeons operating on the neck as well as the lower limbs, it made me reconsider whether I should even set a CVP. But on hindsight, I should have probably good working IVs before I allowed the surgeons to start on the case. One of the attenuating factors I felt was I was able to communicate early with the team and express my concerns. And so as a result, we could identify the problem early. We managed to I managed to inform the surgeons. We managed to get a CVP in the femoral vein and started blood transfusion early. So the patient didn't have a bad outcome, was sent to ICU, but managed to be extubated that afternoon. So on reflecting back, could the adverse event be avoided? Probably not the bleeding episode, but I felt that there was a slight delay in the resuscitation because I didn't have a working IV, and that could have been avoided. So now I've learned from my lesson. I think one of the factors that made me rush was that every time when as a junior, whenever I speak to surgeons, they'll tell me that, oh, my surgical time is shorter than your anesthesia time. So I always feel that need to rush through and let the surgeons begin. But this event has actually changed my attitude. I feel like I should always make sure that I have adequate preparation, and I should anticipate complications that can happen from surgery, and a short delay in starting surgery may benefit the patient, as setting CVP under drapes might not be ideal, and that might cause further delay. Yeah, so that's my little reflection.
Thanks, Jacqueline. And
thank you. Yeah.
Thanks, Jacqueline. Actually, Jacqueline, what you have actually demonstrated to us, like what Nigel and think Li Min said is that hearing from your reflection, right, as faculty, we do need to sort of be trained on how we manage some of your reflections. Because we cannot assume that just because we are seasoned educators, we are also good counselors, or we can actually sort of manage the more emotive aspects of your reflection, right? And the other thing that actually we point out earlier is that a safe and secure environment, you feeling safe and secure in giving feedback like this is actually quite important as well. And I think you're able to do it because you actually have a very strong and trusting relationship with Farida, right? So I will say that if I'm actually meeting a learner for the first time, if I actually do not have a rich and trusting relationship like the both of you, he or she, her reflection might be very superficial. It might be a sort of objective kind of information reporting rather than an emotive reporting. Yeah. I suppose if we are in a sort of a more private setting, I will sort of ask you more questions about your insecurities, your fears, you know, of which I think a lot of the learners they do have, you know, and a lot of them, they actually carry with them the burden of not doing well, especially if a clinical case were to turn sick or turn ill. They take on the burden of feeling responsible for outcomes. But actually, as seasoned clinicians, we know that sometimes these outcomes are not preventable. So this is where I find reflection is actually very important for wellness as well. That, you know, we communicate, we sort of counsel to say that this is the overall clinical picture. Yeah. Farida, any inputs?
Yeah, I think it was nicely done. Jacqueline went through all the phases, right, of the ALEC model, where she actually described what she encountered, but beyond that, she also shared, right, her analysis of the situation, and there's some emotion involved, right, and after that, that's looking back, right, and she then create a new knowledge, right, on top of integrated with what had happened, what she encountered, and possibly will in the future when she come across the same kind of case, she has her own, she has developed her own learning points, okay, and strategies to manage the kind of similar case in the future. Yeah.
Shall we hear from?
Thank you.
Yeah. Shall we hear from Peter from a surgeon's perspective? Peter, are you okay to share?
Yeah, sorry. Yeah. Hi, Nigel.
Hi.
Can you hear me?
Yes, we can hear you.
Yes, we can.
Yes. Sorry. I'll say again. I just having a department meeting going on at the same time. Okay. Yes. Sorry.
We can hear you. We can hear and see you. Yeah.
Okay. Sorry. What was your question?
Okay. So from a surgical perspective, right? I think it's probably quite similar to anesthesia, whereby sometimes the error of margin is actually quite narrow, and residents actually do feel burdened with poor outcomes. So would reflection or a reflective program be able to deal with some of this so-called or burden, feeling of burden?
Yeah, you know, I have to be very careful how I say this. You know, surgical residents, I think, especially neurosurgical residents, may be a slightly different breed, you know, from, you know, medical residents and anesthesia residents. You know, the one thing why they come into surgery and why they come into neurosurgery is, you know, they want to operate, right? You know, they want to operate, and you know, everything is gauged by how much do they get to operate, how much do they do, and you know, that sort of stuff. And we find this very difficult tension between trying to train them, trying to get them to be reflective both before, during, and after surgery, and also uphold very high standards of patient care and patient safety. And then in our discipline in particular, this is very, very challenging because unlike other disciplines, especially if we are doing a microscope case, it's often either us or the resident, It's difficult to operate 2% at the same time. So when we do so, we have to give them over the entire case, and then we look at the assistant microscope. So it is quite difficult and quite challenging. And every resident is different. We have those that be very keen to operate, and I say have a higher tolerance for complications and bad outcome. And those that are very, very sensitive, where one bad outcome, they are devastated, they sink into a severe depression. So I think it has to be really individually tailored, and to each individual resident. And then the problem is we multi-sites, a few residents, and they rotate. So there's not really one mentor that follows the resident throughout. And I think it's important to have a particular mentor that the resident feels that he can get along with. But then on the other hand, the mentor must also be very, very cognizant what values is he transmitting to the resident. Often I find that a resident who loves to operate will find a mentor who loves to let him operate, and that may not be the best combination. In fact, I think a resident who loves to operate may be better with a mentor who does not let him operate very easily until he's proven himself every step of the way, for example, So these are the very, very unique challenges, because when a complication has occurred, it can be very difficult for us to reverse that process. So I find that for me, what I do is I try to do this reflective thing both before, during and after surgery. So spend time, talking to them, try to do a simulation. We use anatomical models in the office, before surgery, go through the anatomy, and then after surgery, we discuss that again. And as you've noticed, I put in the comment, sometimes I just say, how would you feel if this was your father and I took another resident through the same thing? And then, they're often shocked, like, no, absolutely not. Then that sort of challenges their paradigms. Yeah. I don't know if I'm rambling, but I'm just, giving some thoughts on the unique challenges from our perspective in neurosurgery. Yeah. I don't think we've got it all worked out, so we'll be interested to hear, from all you experienced educators, how to do this better.
Yeah. Thanks. Hey, Peter, you're not rambling. Actually, I pick up quite a number of points that resonated with me. I think number one, like what yourself and Sandy has pointed out, the residents need to feel safe. You also mentioned that actually time with learner is actually very important. You can't rush through a reflective process. And like what you say, sometimes it has to plan and guided as well, pre-op, intra-op, and post-op guidance. So you can't be like transmitting along the corridor as well.
Yes, indeed. It has to be very deliberate, very planned, a lot of time mentoring, a lot of coffee and tea and lunch maybe.
Yeah, and one very important keyword that you mentioned just now is actually individualized, because sometimes we feel that by having a program, we can cater to all needs of all learners, but we have to understand that reflection is actually a very intimate process, and each resident or learner may have his own style of reflection. And like what Mariam said just now, she was actually asking, right? We did ask our residents to do in report writing, but not all of them are actually comfortable with report writing. Some of them, they prefer to actually articulate and share on a one-to-one basis.
Yeah, so I'll give you a few examples. Again, it may sound rambly, but sometimes residents will, because our cases are so long, and all that, they spend all day with a very complex case, and then I come out and then I say, okay, reflect. How did you feel today when with this so-and-so senior surgeon? So it will range from, very interesting case, very challenging case. I saw a very experienced surgeon do it. 2, a complete waste of time. And wow, 18 hours in operating theater, I didn't get to do anything at all. You know, shit, I'm never going to get back into this theater again. Don't ever put me in this theater and all that, you know. So, you know, you have this variation, and then you try to tell them, you know, it's not about doing, you know, of course you want to do, we want to let you do, but these cases can be so dangerous, you know, the difference between life and death can be millimeters, seconds, microseconds, you know. So, you know, you see a very experienced surgeon, but it's so boring, stand there for 18 hours, you know. And how to bring these people, you know, up to that stage.
Yeah.
Not easy.
Maybe shall we hear from Vidya? Vidya says in Sengkang Radiology they actually have a mindful reflection program. Vidya, are you okay to share?
Yeah. Can you hear me?
Yes, loud and clear.
Yeah. So it's just a pilot exercise that we just started, maybe about 5-6 months, or maybe less. That we thought maybe, you know, because there were a few complaint cases, and I thought, you know, why can't they? Why are they? You know, these simple things. Why don't they understand? And I thought, you know, it's wrong of me to try and get them to do what I think is right. So instead, I thought that we should probably just sit together first, and, you know, like, try and get them to actually reflect from these complaint cases. So I collected all the prior complaint cases from previous MOs, collated them, anonymized them, and then we started this in a small, called all the trainees. And then we are also promoting mindfulness in our department. So the faculty who is promoting mindfulness and me, we both got together, and we thought we got all the trainees together as well, put out the cases, and then we just discussed various perspectives of what happens with that complaint. So one complaint case, what happens with that complaint case, what's the fallback effect on the radiographers or the nurses or the patients. You know, the different perspectives all come on there together when we discuss these cases. And it just, you know, for everyone sitting there, it's just opens up their mind to, you know, even simple things like every action of theirs or inaction of theirs has consequences. So those kind of things are brought out. Then we, then after that, we got a bit more confident, and we brought out cases like, how do we deal with negative feedback? How we have personally have dealt with negative feedback, and what are the emotional challenges we face, and how we overcome them. Those kind of little you know, sharing that we do in that group. We don't get other faculty involved, because I think if we get more faculty involved, we thought that perhaps the trainees may not feel that comfortable. So we get everyone to share something, and if they're not comfortable, we just leave them. But most of them, you know, come out and say something. So we have broached those topics, positive feedback, negative feedback, bullying and how to face it, and how to unburden yourself. And as somebody mentioned here, how to not blame yourself for the negative outcomes of the situation, and how not to carry it to the next day and just move on.
Yeah.
So yeah, it's a small pilot thing that we have started, and we seem to be getting decent feedback as well for it. So people feel the feeling, overall feeling is good from the residents. So yeah, so I just wanted to share.
Well, Vidya, thanks for sharing. I think, you know, very good ideas, you know, great ideas. And one of the reasons why we felt that the program was very important was that, you know, in each of our system, right, sometimes residents are actually asked to answer complaint letters or to fill up critical incident reports. And one of the things that disturbed us was that the residents came to tell us that I only reflect when I'm actually asked to fill up this critical incident report, meaning that they're actually only reflecting from mistakes and not from good learning. And hence, you know, we so-called with the portfolio, we are hoping to actually switch from not so good learning to sort of good learning from best practices.
Yeah, absolutely. I was intrigued by that aspect in your paper. I never thought that, you know, we should encourage them to reflect on positive, or on days that have gone without any critical incidents. So yeah, so probably it was a mind opener for me as well.
Thanks, Vidya.
Thank
Any
you.
we have 5 more minutes. Any more inputs from any participants?
Yang Yan want to share something, Raymond? Yang Yan wanted to share something about I forgot what it was. Sorry, Yang Yan. Yeah.
No, I just shared 2 readings. So Dr. Simon Ong, Dr. Mok Yi Hui, and Dr. Prita Madhu Kumar actually did a study, a project where they trained their residents on how to do reflective writing. So the 2 readings were actually used by Dr. Mok to train the residents as well as faculty who gave them feedback. Yeah. So a lot of the points you guys raised were also experienced by this particular group, like people who no volition, because it was mandatory training. So some of them were a little bit unhappy and didn't really feel that they were at ease to share the emotive parts of their reflection. Yeah, so quite a few points of commonality. I also like to revisit what Raymond, Nigel, and Sandy said about the issue of trust, relationship building. Yes, that seems to underpin how at ease residents will reflect and how much they can benefit by it. Yeah.
Yeah, right. And based on that, Yang Yan, I feel that possibly it's very challenging to try to set up a reflective program if the learners rotate through your system on a very short-term basis, like 4 weekly or 8 weekly. We were able to do that because the residents actually have a 2 or 3 year relationship with us, and we sort of know them both professionally and socially, and we sort of form a trusting relationship.
Yeah.
Okay. So in closing, what we actually like to encourage everyone to sort of look through the materials, and if you like to sort of collaborate with myself, Farida, or even Vidya on mindfulness, reflection, feel free to approach us, and we're all happy to share our materials. Okay. All right. So with that, thank you very much. Have a good weekend ahead. Thanks.
Thank you.
Thanks, Jacqueline.
Thank
Thanks,
you.
Farida.
Thank you. Thank you, everyone.
Thank you. Yeah.
Thank you.
Thank you.
Bye.